Ever been staring at that list of childhood jabs, maybe wondering what they all are and, when they're actually needed?
Hmm.
It can feel like a bit of a medical puzzle, right?
It really can.
Well, welcome to the deep dive. We take complex health information and basically break it down so it's easy to understand.
And today we're tackling a really fundamental area of child health. The UK's childhood immunization schedule. We've got the official guidance from the Department of Health, their Immunization against Infectious Disease Handbook,
Right.
and also the straightforward information you get from the NHS website. Our goal really is just to give you a clear, high-yield understanding of this crucial preventative measure.
Exactly. Think of this as your shortcut to getting the essential knowledge. We'll be looking at situations where vaccination might need a bit more thought, perhaps.
Yeah, some caution.
The specific vaccines given at different ages, why some older vaccines aren't used anymore, and some key background on how these programs are put into place and the sort of important considerations around them.
It's definitely natural to feel a bit overwhelmed by the sheer amount of information out there about immunization.
For sure.
But hopefully by the end of this, you'll have a much clearer picture of how the UK protects its youngest citizens from preventable diseases.
Okay, let's unpack this then. Let's start with when a vaccine might not be the right choice, at a particular moment.
Okay, so the most important absolute contraindication is a history of anaphylaxis.
Right, a severe allergic reaction.
Exactly. To a previous dose of a vaccine that contained the same components. So, for instance, if a child had a really serious reaction to their first dose of, say, the 6-in-1, they wouldn't receive another dose of that specific vaccine.
Okay.
And similarly, a confirmed anaphylactic reaction to a specific ingredient within the vaccine, like egg protein, which you find in some flu vaccines, that would also mean that vaccine shouldn't be given.
Right, so we're talking about significant immediate allergic responses here. What if a child just has a bit of a fever or maybe a cold?
Ah, okay. In that case, it's usually a reason to delay vaccination.
Just delay, not avoid completely.
Exactly. If a child has a high temperature or an active infection going on, it's generally best to wait until they've recovered. This is mainly just to avoid any confusion about whether any new symptoms are down to their illness or maybe a reaction to the vaccine.
That makes sense. And I know some of the vaccines are live vaccines. Are there any sort of special considerations for those?
Yes, definitely. Live vaccines, like the MMR vaccine, for example, have a couple of main contraindications. They are generally not given to pregnant women
Okay.
or to individuals who are immunosuppressed.
Right.
So immunosuppression just means their immune system isn't functioning quite as effectively as it should. This can be due to various things like being a transplant recipient, maybe undergoing chemotherapy or living with HIV. In those sorts of situations, it's absolutely essential to get specialist advice before giving any live vaccines.
Okay, that's really important to remember. Now, there are probably things that parents worry about that actually aren't reasons to avoid vaccines, right? I've definitely heard a few concerns over the years.
Oh, absolutely. And it's really crucial to clear up some common misconceptions. Many common childhood conditions are definitely not contraindications.
Like what?
Well, things like asthma, eczema, even a history of seizures. Although it's probably wise to have fever-reducing medication like paracetamol or ibuprofen ready if seizures are triggered by a high temperature.
Good tip.
And breastfeeding. That's definitely not a reason to delay or avoid any vaccines.
That's good to know and will reassure a lot of people, I think. What else is on that not a contraindication list?
Well, having had the natural infection before, like maybe whooping cough or measles, it doesn't mean the vaccine isn't needed. Vaccines can often offer more reliable, sometimes broader protection.
Okay.
Also, things like a history of jaundice in newborns or family history of autism, absolutely not a contraindication. Neurological conditions such as Down syndrome or cerebral palsy.
Not a reason either.
Nope. Being born premature or with a low birth weight, and even being on replacement steroid medication for conditions like congenital adrenal hyperplasia, none of these are reasons to skip routine vaccinations. The main goal is always to protect all children.
That's really clear and reassuring. So, okay, let's get into the schedule itself.
Yeah.
What's usually the first vaccine a baby might receive?
Right at birth, or very soon after, the BCG vaccine is offered, but only to babies who are considered to be at higher risk of tuberculosis.
And what counts as higher risk?
A key example would be if there's been a case of TB in the immediate family, within the last 6 months, or if the baby's parents or grandparents come from a country with a high rate of TB.
Okay, so it's targeted. And then what happens around the 2-month mark? Or is it 8 weeks now?
Yes. The schedule usually refers to 8 weeks now, which is around 2 months. At this point, babies typically receive the 6-in-1 vaccine.
It's a big one.
Yeah. This single injection protects against 6 diseases: diphtheria, tetanus, whooping cough, that's pertussis polio, Hib, which is Haemophilus influenza type B.
That causes nasty infections in kids.
It can, yes, like meningitis and epiglottitis, and also hepatitis B. You might see it under the brand name Infinrix Hexa.
Okay.
At this same visit, they also get the oral rotavirus vaccine, often branded as Rotarix, which protects against that common cause of really quite severe diarrhea and vomiting in infants.
Right.
And they'll also receive their first dose of the MenB vaccine, protecting against meningococcal B disease brand name, usually Bexsero, and the PCV, the pneumococcal conjugate vaccine, typically Prevnar 13.
Phew. Quite a lot at once.
It is. Now, there's a slight difference here for babies born after January 1st, 2020.
Ah, okay.
Their PCV doses are given a bit differently at 12 weeks and then again at 1 year, not at 8 weeks and 16 weeks like babies born before that date.
Right. That's a key change to note. So what about the 3-month mark or 12 weeks for those babies born more recently?
So at 3 months or 12 weeks for those born after January 2020, they'll have their second dose of that 6-in-1 vaccine and their second dose of the oral rotavirus vaccine. And as we just mentioned, babies born after January 1st, 2020 will also get their first dose of the PCV at this stage.
Got it. And then at 4 months or 16 weeks?
At 4 months or 16 weeks, it's the third dose of the 6-in-1 vaccine. They'll also get their second dose of the MenB vaccine.
Okay.
And for babies born before January 1st, 2020, they will receive their third and final infant dose of the PCV at this point.
So the PCV schedule definitely depends on the birth date. That's important.
It really is.
Right. What's next in the timeline after that 4-month visit?
Okay, so the next key point is between 12 and 13 months. Around the first birthday, there's another important set of vaccinations then.
Okay.
This includes the Hib C vaccine. It's a combined injection that boosts protection against Hib and provides the first dose protecting against meningitis C.
Right.
They'll also receive their first dose of the MMR vaccine, that's measles, mumps, and rubella. Common brand names are Priorix, or MMR VAX Puro.
The first MMR, okay.
And then the PCV babies born before 2020 get their booster dose here, while those born after January 1st, 2020 will receive their second and final dose at this age.
Okay, so that PCV schedule difference again?
Yes. And finally, they'll have their third dose of the MenB vaccine. So you see, by their first birthday, they've had significant protection built up against a whole number of serious illnesses.
That is a busy first year for jabs. What about after their first birthday, as they move into toddlerhood and beyond?
Well, between the ages of 2 and about 8 specifically, until the end of primary school, children are offered an annual nasal flu spray.
The spray, not an injection.
Usually, yes. It's often called Fluence Tetra. For children aged 2 up to 4, this is typically done at their GP surgery. But for primary school-aged children, so reception up to year 6 usually, they typically receive it at school.
Okay.
This really targets those age groups where flu can spread very easily in close contact settings like nurseries and schools.
That makes sense. And then around preschool age, is there anything specific then?
Yes, at 3 to 4 years old, they'll get their 4-in-1 preschool booster.
Okay, another combination.
Yes, it's another injection protecting against diphtheria, tetanus, whooping cough, and polio. You might see it referred to by brand names like Repivax or Boostrix, IPV.
Right.
And they also receive their second dose of the MMR vaccine at this stage. This really helps to reinforce their immunity against measles, mumps, and rubella. It gets those antibody levels right up.
Okay, second MMR, done. And as they get a bit older, heading towards secondary school.
Right. Between 12 and 13 years old, so usually in year 8 at school, both boys and girls are offered the HPV vaccination.
HPV.
Yes, human papillomavirus. It protects against types 16 and 18, which are the main causes of cervical cancer, but also other cancers affecting both men and women.
And it's 2 injections?
Usually, yes. A course of 2 injections given 6 to 24 months apart. The brand is typically Gardasil.
Okay, and then around 14 years old, any more?
Yes. At 14 years old, usually year 9, there's a TDIPV booster. Yeah, it stands for tetanus, low-dose diphtheria, and polio booster. Often uses the brand Revaxes.
Okay.
And they also receive the men ACWI vaccine at this age. This provides protection against 4 types or serogroups of meningococcal disease: A, C, W, and Y.
Ah, yes, I remember hearing about the rise in men W cases.
Exactly. This vaccine was specifically introduced to combat that rise, and it has replaced the old Menc-only booster for this age group. Common brands are Niemann-Rix or Menveo.
Right. What about older teenagers then? Say in their late teens.
Well, technically, that 14-year-old TDIPV is often called the 3-in-1 teenage booster because it covers tetanus, diphtheria, and polio.
Uh-huh.
But it's also really important for those who might have missed the men ACWY at 14, or particularly for those heading off to university, so school leavers, maybe year 13, and new university students up to the age of 25, they really need to make sure they've had their men ACWY vaccine.
Why particularly that group?
Because university students, especially in their first year living in halls, are at higher risk of meningitis and septicemia due to mixing closely with lots of new people. The NHS advises these students to contact their GP to get this vaccine, ideally before they start term.
That makes a lot of sense. So it's not just about school kids, but also protecting young adults in those environments.
Absolutely. And while our main focus today is childhood immunization, we probably should quickly mention adults too.
Good point.
There are things like the annual flu vaccine and the PPV, that's the pneumococcal polysaccharide vaccine for people over 65 and those in high-risk clinical groups.
Okay.
The TDIPV booster is available for adults who maybe weren't fully immunized as children or perhaps need it for travel to certain areas. Pregnant women, as we'll touch on again, are offered the DTaP-PV vaccine from 16 weeks, mainly for whooping cough protection for the baby.
Right, that's important.
And there's also a shingles vaccine offered to specific older age groups, usually around 70-79.
That gives a really comprehensive overview of the whole schedule, right from birth up to adulthood. Now, you mentioned earlier that some vaccines have been discontinued. Could you tell us a bit more about that, how the program evolves?
Yeah, certainly. A key example is the meningitis C, or Men-C, vaccine that used to be given to babies at 3 months old. That dose was actually discontinued back on July 1st, 2016.
And why was that?
Well, it wasn't because it was ineffective. Quite the opposite, actually.
Oh, right.
The Men-C vaccination program that started in 1999 was incredibly successful. So successful, in fact, that cases of Men-C disease in babies and young children in the UK became extremely rare.
Wow, that's amazing success.
It really is. And it highlights how these public health programs adapt. When one disease is really well controlled, resources can sometimes be shifted to address other emerging threats, like the rise in Men-W disease we mentioned, which led to introducing the Men ACWY vaccine later on.
So the protection isn't lost.
No, definitely not. To ensure continued protection against Men-C, all children still receive the combined Hib-Men-C vaccine at around 1 year old, and then the Men ACWY vaccine at 14 years old covers C again alongside A, W, and Y. So together, these provide coverage across all the key age groups.
That's good to know the protection is still there, just delivered perhaps more efficiently now, reflecting the changing disease patterns. Now, looking at some key information and when these vaccines were actually introduced, it sounds like there's quite a history behind this schedule. Looking at these dates, you can really see how medical science and, I guess, specific disease threats have driven how this whole thing developed.
Oh, there certainly is a rich history. It's quite interesting. For instance, it's generally thought that 5 doses of diphtheria, tetanus, and polio vaccine throughout childhood are enough for long-term protection for most people.
5 doses.
Yes. However, as we touched upon, the DTaP-APV booster, that's the one containing pertussis 2, is offered to pregnant women from 16 weeks, but optimally between 20 and 32 weeks. That started in September 2012 because there was a worrying rise in neonatal whooping cough cases.
Protecting the newborn.
Exactly. And tetanus boosters might still be advised for adults, maybe for travel to high-risk areas or after certain types of dirty wounds, especially if the last booster was more than 10 years ago.
And what about the BCG vaccine again? Just to clarify, that's quite targeted, isn't it?
That's right. The BCG vaccine against tuberculosis is only given to those considered to be at high risk, like we discussed family history, country of origin. If a baby needs it, it's usually given in hospitals soon after birth. If it's needed later, a referral to the local community pediatric or chest clinic is usually required.
Okay. And we also touched on the HPV vaccine now being offered to boys as well as girls.
Yes, that started relatively recently. The HPV immunization was introduced for boys aged 12-13 years, the same age as girls. What's important to note is that, unlike when it was first introduced for girls, there wasn't a big catch-up program for older boys.
Why was that?
The decision was based largely on the fact that the vaccination of girls had already led to significant herd immunity.
Right, indirect protection.
Exactly, which offers quite a good level of indirect protection to boys as well, reducing the overall circulation of the virus.
Interesting. And we've already mentioned the 2020 update to the PCV schedule a couple of times. It's definitely helpful for parents to remember those birthday cutoffs.
Absolutely. Keep that January 1st, 2020 date in mind for PCV. And, for anyone interested in the historical context, the UK has been rolling out these life-saving vaccines over many decades. It's quite a timeline.
Yeah, give us a sense of that.
Well, diphtheria vaccination started way back in 1940, pertussis, or whooping cough, in the 1950s, BCG in 1953, polio vaccine came in 1955, tetanus in 1961, then measles in 1968, rubella separately in 1970, and then the combined MMR finally arrived in 1988.
Okay, so MMR is relatively recent in the grand scheme.
Compared to diphtheria, yes. Meningitis C came in 1999, pneumococcus, PCV in 2006, HPV for girls in 2008. Then we had rotavirus and shingles, along with the children's nasal flu vaccine, all starting around 2013. Meningitis B and the MenACWY vaccine in 2015. And most recently, that hexavalent 6-in-1 DTaC IPV HiPep vaccine was introduced in 2017, replacing the 5-in-1.
That's fascinating. Knowing those dates could sometimes be helpful, maybe for healthcare professionals, in identifying older individuals who might not have been routinely offered a particular vaccine when they were younger.
Exactly. It helps understand potential immunity gaps in the population.
Okay, that historical timeline really puts things into perspective. Now let's maybe delve just a little deeper into some of those cautions and contraindications again. You gave us the general overview, but are there any specific details worth perhaps highlighting?
Yes, definitely. The key message is always, if in doubt, seek expert advice.
Right. Don't guess.
No. This could mean consulting a consultant pediatrician or physician, maybe the local immunization coordinator, or a consultant in health protection. When we talk about anaphylactic reactions, it's not just about a previous reaction to the same vaccine. It also includes a confirmed anaphylactic reaction to any other component in the vaccine.
Okay.
We mentioned egg protein before, but other examples could include trace amounts of antibiotics like neomycin, streptomycin, or polymyxin B that might be present in some vaccines from the manufacturing process.
And what about common allergies like egg or latex? I can imagine parents might be particularly concerned about these, especially egg allergy.
Yes, it's a common question. For individuals with a confirmed anaphylactic reaction to egg, a severe immediate reaction, it's important to know that they should generally not receive influenza or yellow fever vaccines without specialist advice first.
Specialist advice is key there.
Absolutely. True egg anaphylaxis is actually quite rare, but for that small number of individuals with a history of confirmed anaphylaxis after eating egg-containing foods, specialist advice should definitely be sought. Immunization might still be possible, but potentially under controlled conditions, like in a hospital setting.
Okay, and latex.
Similarly, individuals with a confirmed anaphylactic reaction to latex should ideally not receive vaccines supplied in vials or syringes that contain latex components, like the stopper or plunger. However, the risk is considered very small, and actually many manufacturers now use latex-free packaging anyway. But again, if there's a known severe allergy, it's worth checking and potentially seeking alternatives.
You also mentioned temporary contraindications for live vaccines before. Can you just reiterate those specific situations?
Yes, sure. So live vaccines, again, think MMR, varicella, chickenpox, rotavirus, nasal flu, BCG, yellow fever, may be temporarily contraindicated in individuals who are immunosuppressed. For the reasons we discussed earlier, their immune system might not be able to handle even the weakened live virus properly. Expert advice is absolutely crucial in these complex situations.
And pregnancy.
And pregnancy, yes. Pregnancy is also generally considered a temporary contraindication for receiving live vaccines.
Okay. And there have been some updates on how close together different live vaccines can be given, haven't there? It's good to have those timings clear in mind.
That's correct. The recommendations were updated, I think, around 2015. Generally speaking, most live vaccines can actually be given together on the same day or at any time before or after each other.
Oh, okay.
But there are a few key exceptions to be aware of. Yellow fever and MMR vaccines must be given at least 4 weeks apart. They shouldn't be administered on the same day.
4 weeks apart for yellow fever and MMR. Got it.
Varicella, chickenpox, and zoster shingles vaccines can be given at the same time as the MMR vaccine. But if they're not given on the same day, then there should be at least a 4-week interval between them.
Okay, same day or 4 weeks apart for varicella, zoster, and MMR.
Exactly. And finally, there's a potential interaction with the tuberculin skin test, which is also known as the MAN2 test, used for TB screening.
Yes.
If someone needs a MAN2 test, any MMR vaccination should ideally be delayed until after the skin test has been read, usually 48-72 hours later. Conversely, if someone has recently had an MMR vaccine, you should wait at least 4 weeks before doing a MAN2 test, as the MMR can temporarily reduce the skin reaction.
That's really helpful to have those specific timings clarified. Okay, moving on slightly, let's talk about the medico-legal aspects of childhood immunization. It's something that does occasionally crop up, often when there are disagreements, perhaps between parents or with healthcare providers.
Absolutely. It's an important area. The usual principles of consent in childhood apply. For younger children, parents or those with parental responsibility provide consent. For older children, the concept of Gillick competency is relevant.
Gillick competency.
Yes, this refers to whether a child under 16 has sufficient understanding and intelligence to understand fully what's involved in a proposed treatment, including its risks and benefits, and can therefore consent to it themselves without parental permission. This could apply to vaccinations for some mature adolescents.
Okay.
In the vast majority of cases, of course, parents do provide consent for their children to be vaccinated. But as you say, there have been some notable legal cases where parents have refused vaccination for various reasons.
And what happens then?
Well, there have been court rulings where judges have had to weigh the parents' views against the medical advice regarding the child's best interests. In several high-profile cases, courts have determined that vaccination is in the child's best interests and have authorized it even when parents objected, perhaps due to specific beliefs or concerns.
So the courts tend to side with vaccination.
These cases certainly underscore the significant legal weight given to vaccination as a public health measure designed to protect not just the individual child, but the wider community. It's also worth noting, as a point of comparison, that some countries, like France and Italy, have actually made certain routine childhood vaccinations legally obligatory for school entry.
Right, different approaches internationally. It
Yeah.
really highlights the importance placed on protecting children and the community through vaccination programs.
Okay, finally, let's touch upon vaccine uptake in the general population. I know NICE, the National Institute for Health and Care Excellence, has guidelines on this, aiming to ensure as many children as possible get the protection offered.
Yes, they do. NICE provides guidance aimed at encouraging and maximizing vaccine uptake. They recommend, for example, that all GP practices should have a designated vaccine lead.
A specific person responsible.
Exactly. Someone to ensure things like maintaining accurate and up-to-date patient vaccination records, proactively informing patients or parents about vaccines that are due, making it easy to book appointments, and sending out reminders. Makes sense.
NICE also highlights various common barriers that can prevent people from getting vaccinated. These can include things like inconvenient clinic times or locations making access difficult.
Yeah, practical issues.
Practical issues, definitely. Also, uncertainty among some people about whether the diseases are really that serious anymore or whether the vaccine is truly needed. Negative past experiences with healthcare or vaccination can play a part, sometimes a lack of trust in authorities or official information sources, and occasionally specific religious or cultural views, which we sometimes see discussed around the HPV vaccine, for instance.
So, what did the guidelines suggest for healthcare professionals? How can they help improve uptake and address some of those barriers?
A key piece of advice is around opportunistic vaccination.
Opportunistic.
Yes, basically taking every opportunity. So whenever someone who is eligible for a vaccine comes into contact with healthcare services, maybe for a routine checkup, an antenatal appointment, or even attending for something else entirely, healthcare professionals should check their vaccination status. They should discuss any outstanding vaccinations, offer them right there and then if possible and appropriate, or at least strongly encourage booking an appointment. They might also consider referring parents who seem hesitant or have lots of questions to maybe a health visitor or a school nurse for further discussion.
So making every contact count, essentially.
Exactly. And to make vaccination easier logistically, practices are encouraged to offer more flexible clinic times, perhaps including some evening or weekend appointments, and also to think about providing vaccination in more accessible community locations, maybe using mobile units or setting up clinics in community centers, children's centers, that sort of thing.
Good idea.
And just to quickly reiterate, those adult vaccines, again, in this context, vaccines like the annual flea jab, the shingles vaccine, and the pneumococcal vaccine are specifically offered to older people and those with certain health conditions. And of course, pregnant women are routinely offered the flu and whooping cough vaccines to protect both themselves and their babies.
So to sort of sum up our deep dive today, what are the key takeaways?
Well, I think the main thing is that the UK childhood immunization schedule is a really meticulously planned, evidence-based program. It's designed carefully to protect children against a wide range of serious and sometimes life-threatening infectious diseases.
Right.
There are very clear guidelines on who should and shouldn't be vaccinated and when. And the schedule itself isn't static. It's regularly reviewed and updated based on the latest scientific evidence, disease surveillance data, and vaccine developments. It really is a cornerstone of public health in the UK.
And its evolution, as we saw with those introduction dates, really reflects our increasing understanding over decades of infectious diseases and how best to prevent them.
Precisely.
And I guess the crucial point for listeners is, as always, if you have any specific concerns or questions about your own child's immunizations, or perhaps your own,
Mm.
it's absolutely vital to consult with your GP, your practice nurse, or perhaps your health visitor. They can provide personalized advice based on individual health history and circumstances.
Exactly that. Don't rely on Dr. Google necessarily. Speak to a professional. And maybe on that note, here's a thought perhaps to leave you with.
Okay.
Considering that historical timeline of vaccine introductions, we talked about diphtheria in the 40s, polio in the 50s, MMR in the 80s, MenB and ACWY much more recently. What does that pattern actually tell us about how public health priorities might have shifted and evolved over time, in direct response to different infectious disease threats?
That's a really interesting question. How society has responded over time.
Yeah, it's a fascinating reflection on our collective efforts to protect public health.
Definitely something to think about. And if you are studying for exams or just want more resources, do be sure to check out passthemsra.com and also freemsra.com for lots of helpful materials.
Great resources.
Thanks very much for diving deep with us today.